welcome to another session of our Neuro Oncologie course at the Association of Future African Neurosurgeons. I am Ulrich Sidney, the founding president of the Association of Future African Neurosurgeons. We'll go around and have everyone present themselves. So starting will be Poster Mutambo.
Good evening, everyone. My name is Mutambo Poster, fifth year medical student from the Kawabet University, Zambia.
Thank you so much, Poster. Next up is Olaoluwa Ezekiel.
Good evening, everyone. I am Olaoluwa Ezekiel Dada. I'm a second-year medical student from the University of Ibadan, Nigeria, a research fellow at the Association of Future African Neurosurgeons. Glad to be here today. Thank you.
We're glad to have you. And then next up is Daniel Safari. Daniel Safari, you're muted. Can you present yourself, please? Okay. Next up is Leslie Jogo.
Good evening, dear all. I am Leslie Jogo, and I am a fourth-year medical student at the Faculty of Medicine and Biomedical Sciences of Garoua in Cameroon, and I'm very glad to be here.
Thank you, Leslie. Next up, Takutsing Berger Dormo.
Greetings, everyone. I'm Takutin Dormo Bejo, sixth-year medical student at the University of Buea, Cameroon, a research fellow at the Association of Future African Neurosurgeons. Happy to be here today.
Thank you. Next up, we have Dr. Natalie Gomsi.
Hey everyone, I am Nati Gomsi, PGY2 neurosurgery resident in Abidjan. I'm really happy to be amongst you this evening.
Well, thank you. João Manuel, can you unmute and present yourself, please?
Okay, hi, good evening, everyone. I am Joel Manuel, second-year medical student from University of Montaigne, Cameroon.
Welcome, and thanks for being here. Okay, so a presenter, like we said earlier, is Genevieve ENDALLE. She's going to present herself and start the presentation immediately. Go ahead, Genevieve.
Good afternoon, everyone. My name is Genevieve ENDALLE, fifth-year medical student at the University of Buea, Cameroon. I'm equally the Secretary General of the Association of Future African Neurosurgeons. So thank you, everyone present here. So I will start by sharing my screen. Okay, everyone can see.
Yes, please, go ahead.
Okay, so today is the sixth case of Neuro Oncologie course. So let me start by presenting the case. So this is a 30-year-old female with no significant past medical history, presents with severe headache, nausea, and blurred vision. The past medical history is unremarkable. Vital signs: blood pressure of 85/40 millimeter of mercury, heart rate of 120 beats per minute, respiratory rate of 14 breaths per minute, a saturation of 99%, and the temperature of 100.3 Fahrenheit, which is equal to 37.9 degrees Celsius. Upon examination, the patient is awake but drowsy, nasal visual fields intact, bilateral temporal visual field diminished to confrontation, left pupil deviated inferolaterally, discontinued gaze, difficulty with adduction of both eyes, full strength and sensation in extremity. So what do you think can be the diagnosis and the differential diagnosis? Anyone can just raise his hand and answer. Please, Dr. you can help me to view those who are raising their hands because I can't see on my screen.
Yeah, obviously. Takutin Bejo wants to go first.
Okay.
Thank you very much for the presentation. So for the presentation, I'll make a diagnosis of a space occupying lesion based on the fact that the patient presented with signs of raised intracranial pressure, that is the headache, blurry vision, and also you have involvement of the optic tracts. So as differential diagnosis, I would think first of all of a vascular cause, probably a hemorrhage at the level of the pituitary gland. This is based on the fact that the patient presented with the signs and symptoms of raised intracranial pressure, and you can see at the level of the vital signs, you see that there's hypotension there, and there's a compensatory tachycardia, and also there's involvement of the optic tracts, meaning that there should be a lesion at the level of the pituitary gland. As other differentials, still vascular, I also think of other causes of intracranial hemorrhage, such as a subarachnoid hemorrhage or rupture of a intracerebral aneurysm. I could also think of a neoplastic cause, a pituitary adenoma, craniopharyngioma, or also an infectious cause such as a meningoencephalitis or intracerebral tuberculosis. Thank you.
Okay, thank you. Anybody else?
Okay, I see Dr. Natalie has her hand raised. Dr. Natalie, please go ahead.
Okay, thank you. First of all, I want to ask some questions about the history. For how long has she been having these symptoms? I would say, if I'm not I'll start by the diagnosis of a pituitary adenoma for this female 30-year-old patient. And as differential diagnosis, I would propose all the diagnosis, an extended pituitary, that's a macroadenoma. I prefer to say macroadenoma because there are already signs of compression. Then, as differential diagnosis, I will propose all the different pathologies which will be related to the zone of the pituitary area. The pituitary area, thus it could be for a 30-year-old woman. I'm a little bit confused because in pituitary adenomas, there are some complications which usually happen that they call, I don't know if you heard about it, apoplexia, where the patient has symptoms are brutal. Sorry, I'm on call, so it's a bit difficult.
No, we understand.
Okay.
Yeah.
So we have the symptoms which start brutally. That's why I was asking that when did she have, you are more precise to say the time. Then for the vital signs, this is not the classical patient triad, as normally we're supposed to have a high blood pressure, tachycardia, and all the other ones are high. So in fact, as differential diagnosis, I will propose in all tumors which can take the area. For example, tumors of the hypothalamic nucleus, tumors of the third ventricle, which extends anteriorly, and yeah, those are my main tumoral infections. Those are my main differential diagnosis. Now, secondly, it can also be an infection. It can also be an abscess of the pituitary gland, which usually causes the same, as the expansion usually causes the same symptoms. That's the second, and not arterial. Okay, those are my two main diagnoses that I would take.
Okay, thank you, Dr. Natalie. Anybody else?
I think we can go ahead.
Okay, so Um, these are our differential diagnosis. We are going to have our diagnosis by elimination. So I think all the participants gave the good contribution. So we can go ahead to look for our diagnosis here. So we have the differential diagnosis. As causes, we have neoplastic, vascular, infectious, or others. As neoplastic, we have pituitary adenoma. It's possible in this case, but usually it present usually is asymptomatic, and usually you cannot have a particular sign and symptoms to give a diagnosis, and it's usually by imaging studies that you can easily give this diagnosis. And also yes, for brain tumors, usually it depends on the onset. So on this case, we can say that it's an acute onset because also the time has not been given. So the presentation on the patient, if they had to maybe emphasize on any part, they will say that the patient had these symptoms maybe for a particular time. So let us assume that it's an acute onset. So it cannot be a brain tumor or metastatic like craniopharyngioma or dermoid or teratoma. So vascular stroke. Okay, stroke. In this patient, we don't have the risk factors. The past medical history was unremarkable, and we don't have any motor focal deficit on this patient, so we can exclude it. For the aneurysmal subarachnoid hemorrhage, it's possible because here we can see that the patient is hypotensive and is tachycardic. So we can think about it. It can be a differential too. Even cavernous sinus thrombosis. Concerning infectious causes, I think we cannot go for infection causes because we can see that the patient does not have a fever and there were no meningeal irritation symptoms or signs. So I think we cannot take any infection cause here. So as others, pituitary adenoma may be our most probable diagnosis here based on the severe headache, blurred vision that we have, and also the hypotension and tachycardia. That means there is hemorrhage, so there is going to be a compensatory mechanism that's going to happen, and we have decreased visual field acuity. That means the optic chiasma has been compressed at a certain level. So for hypophysitis, here is the inflammation of the hypophysis. So here is mainly we can say it is occur mainly in patients who undergo radiotherapy usually. So, and they do not indicate in the past medical history that the patient have any relevant past history. So we can also think about Sheehan syndrome because she's a female, and it's less likely because they did not emphasize if the patient was pregnant before, because we have normally it's occur during after postpartum. So we can have a large volume of hemorrhage, which can lead to hypovolemic shock, and it can result to necrosis of the anterior pituitary cells. So they did not indicate that the patient was pregnant or not. So for the rachis cleft cyst is less likely because here the patient is something that can happen in long term. It's not something acute. And also migraine is not, it cannot be because the patient with migraine cannot have present with hypotension and with hypotension. So for our most probable diagnosis here is it could be pituitary hypoplexy, but clinically we cannot take it as a diagnosis. So we surely go for further studies to rule out our diagnosis. So what next for investigation that we can ask in this case? Any person can answer, please.
Dr. Natalie's hand is raised. I'll start with Dr. Natalie and then we'll go to Bejo.
I wanted to.
Yes, please go ahead.
Okay, let me go. I wanted to tell Ndale that I am okay with all her differential diagnostics, but you know there are some pathologies that you ruled out or you took, which were not really to be ruled out like that. You know, pituitary apoplexia is a case where you have an adenoma first, which bleeds secondly. And then there's a rapid increase in the rapid increase of the size of the adenoma, which causes acute symptoms, just like stroke, all related to. Then for the other brain tumors, you could not really rule out the other brain tumors. You know, pituitary adenoma is also a tumor, and it's not always asymptomatic as you think. It depends on the size. If the size is small, then it can be asymptomatic if it is not non-secretant, it does not secrete hormones. But if it is secretant, then you can have endocrine signs of the different parts that exist there, like the corticotrophic, the gonadotrophic, and the others. So it's not always asymptomatic. Then for the diagnosis of aneurysmal subarachnoid hemorrhage, one thing that could rule out also this diagnosis was the fact that the patient was not presenting meningeal signs. And you can also totally rule out infectious causes because, you know, in some pathologies or some infections, you can see usually some abscess, like toxoplasmosis. You rarely find a patient who has fever. So it does not rule out the fact that there could be an abscess. We've got a case here where the patient had an infection, hypophysitis, an abscess of the pituitary gland, and she was not even presenting any signs of disequilibrium in her vital signs. So it could not be totally ruled out. Now to push forward, I will not answer for the investigation because I think my younger colleagues can answer for that. I just wanted to draw your attention to those differential diagnosis.
Please go ahead.
Okay, any question for any investigation that we can go forward?
I think Poster Mutambo has his hand up.
So I think some of the investigations that we can do in this patient, I think we can, under radiological investigations, I think we can do a CT scan. Yeah, a CT scan of the head, then also do an MRI of the head. Yeah, I think those two. Yeah, and I think we can also do an EEG. Yes. Thank you.
Thank you.
So I just want to get back. So poster, it's not like what you're saying, it has some value, but the question really is, first, before you answer what investigations, you need to get back in your mind, what were we suspecting? And then ask yourself, what is the best way to confirm or eliminate those diagnoses? If you really need to, what I really want everyone to learn today for the students is the whys, not the, the why, the how. It's not the answer. So it would help you to have a fully formed phrase. So think, okay, if it was a neoplasm and I wanted to confirm a neoplasm, I would ask this. If it was an infection and I wanted to confirm an infection, I would ask this, okay? If you do that, you will see that you will get a lot more out of this, okay?
Oh yeah, thank you, Mr. Eric. Okay, for me, okay, the reason why I was thinking maybe my guidance was from okay. So this is okay. These investigations I have to give are based on the fact that we haven't yet reached a diagnosis. Is it?
Yeah, exactly.
Oh, okay.
I have a question
Okay.
is this postpartum, right?
Poster. Yes.
Okay. Poster, why would you ask a CT scan? What's the reason for you to ask a CT scan to this patient?
Okay, yeah. So the reason why I would think of a CT scan is that in the first place, we're thinking of a space occupying lesion. Yeah. We're thinking of a space occupying lesion, of which is a CT scan is one of the radiological investigations that would help us appreciate brain tissue or soft tissues such as the brain, and to rule out any pathologies.
Let me help you out.
Okay.
Let me help you out. You're using keywords. I want you to just get there. You use a very important word, which was soft tissues. What is the best way to visualize soft tissues?
Okay.
In the brain.
Yeah, the best way to visualize soft tissue in the brain is an MRI. MRI is the best.
And do you think there is value in asking both an MRI and a CT scan?
Okay, yeah, there is value in that. Okay, I'm looking at it from the point of our setup here in Africa. Yeah, seeing that one, most of the centers might have access to a CT scan than an MRI. So that's why I would try to order a CT scan, because I know at least patients would have access to the CT scan than an MRI. Yeah, and that would be easy for me to maybe try to confirm the diagnosis, if my diagnosis is right or wrong.
Okay,
yeah,
so here's the thing. It's good that you understand that. So here's the thing. Since you know the MRI is better, okay?
Yes.
Start by answering MRI, and then you can add that reason, saying that if the MRI is not available, I will ask for a CT scan, okay?
Yeah.
Do not get used to asking the alternative.
Okay.
Okay.
This is a theoretical exercise. It's not practical. Okay, I understand what you're saying. I agree with you. So ask for the MRI.
Okay. Yeah, you ask an MRI, but you'll be surprised. But you're supposed to ask a CT scan to this woman. Why? I'll explain to you. Okay. This is for surgical purpose.
All right.
Before endoscopy, normally, I'm sorry, maybe I'm going far ahead. I don't know what to follow next. For surgical purpose, you're supposed to do a CT scan of this of the sinuses, to see the relation that the tumor or the lesion is having with the sinus, the sphenoid sinus, because usually for surgery, you usually pass through the sinus, and you have to give what is called the types of the sinus, because they are really different. They are different in that it varies between people. Usually, you have 3 types, so you have to give the type of sinus that you have, and that will facilitate access for endoscopic surgery. So yes, you ask a CT scan, but it will not be for you. It will not be the exam of choice to evaluate the lesion.
Okay.
Do you understand, poster?
Yes, I understand.
So what we do usually is that we ask both, but it's just to type the talk on the CT scan just for a better vision of the bone, that's of the cranium of the bone and the sphenoid sinus. Then lastly, you ask for an EEG. I didn't understand why.
Oh, okay, I think on the EEG, I think I refute that one. Yeah, I wasn't supposed to put it there. Unless maybe if the patient maybe had seizures or something, maybe I would have requested for the EEG. But for this one, I think I don't see any need of requesting for an EEG.
Then for the MRI, this is under the cover of Dr. Sydney and others.
Okay.
Is it the MRI of this? Is it the brain MRI or the pituitary or the pituitary MRI that we are supposed to ask for?
Okay, for this patient, I think getting a brain MRI would be the best. Yeah, seeing that knowing the location, when you know the exact location of where this lesion is, it would help you correlate the location of the lesion and also the clinical presentation. Yeah.
It's poster. You were answering poster?
Oh yeah, I was answering.
Oh, okay. Usually to be more precise, the cuts for a pituitary MRI in radiology is really different from the one from a brain MRI.
Okay.
Usually you have to go, I think for brain MRI, something like 1 millimeter. But for pituitary MRI, you have to, the cut has to be 3 millimeters. That's, you have to enlarge the space for a better vision. So what they usually do is you ask, well, this is what happens here, but normally in our context, this is what happens. You have to ask for the MRI of the pituitary region so that the radiologist will focus on all what's linked to the pituitary region. He'll even focus more again, he'll even do an MRA, that's an angiography, to see the relationship between it is a highly vasculated region, the space that the pituitary gland takes, and above it, it's at the center of the Bell's skull. And usually you have arteries like the carotid artery, which passes laterally and above it, you have the main anterior circulation of the brain, which is over there. So we push forward to do that. They do an exploration, which is really different from when you ask. But I don't know, I think that's mainly in our context. In developed countries, I think they have developed it in such a way that when they find a lesion, they will go forward to that lesion and then go forward to that lesion and then give results, even though it was not asked by the physician.
Okay.
However, did you finish speaking, or was that all, or you wanted to speak more again?
No, I think that's the only thing. Yeah, those are the only ones that I had.
I don't know if somebody else wants to speak, but I would advise you.
I wanted to add on the other tests that you can carry out.
Okay, then continue. I'm sorry.
Yeah, so I was thinking we can also do laboratory tests in the same. Yeah, we can also do some laboratory tests. You can do a lumbar puncture and do CCF for culture microscopy and sensitivity. We can do those. We can do those. We can also do acid fast bacilli for CCF throughout tuberculosis. Oh, CSF for acid bacilli for CSF. Yeah, you can do that one. Yeah.
I'm sorry.
That is to rule out. Sorry. I think that was to rule out the other differential diagnosis, right?
Yeah, the infectious, the infectious ones.
Okay, I just wanted to remind you that we are talking about the pituitary gland. So, haven't you forgotten something?
We're supposed to do hormonal profiles. Yeah, hormonal profiles.
I want to ask you a question.
Endocrine dysfunction. So to do the diagnosis of pituitary apoplectic, we have to take a good history and also a good physical examination. And we, as to confirm our diagnosis, is mainly by imaging studies, MRI and CT scan, but the gold standard is the MRI. As laboratory studies, we can request for full blood count, coagulation studies, prolactin, LH, FSH, ACTH, TSH. We can ask for T3, T4, growth hormone, and glucose level. So for the management of pituitary apoplexy, we will apply the ABC. A, which stands for airways, that means we ensure that the airways are free. If there is any foreign body, we can remove, and the airway should be free. And B for breathing, like if the saturation level is low, we can put the patient on oxygen or intubate the patient, and to see if there's any chest deformity. And for C for circulation, that means we monitor the vital signs, blood pressure, heart rate, respiratory rate, saturation. And if the patient is hypotensive, we can put 2 IV lines to resuscitate the patient. And secondly, we will take a sample collection, blood for sample collection. We do a cross match and also check baseline hormonal level. And we reserve the patient for surgery if the case is getting worse, but we have to know that this is an emergency when a patient is diagnosed of pituitary apoplexy. So if the patient is getting worse with loss of consciousness, or we have visual field defect, the patient can be suddenly blind, we can rush for surgery at that time. And we can also refer the patient to see the specialist, like the neurosurgeon, the ophthalmologist, and even the endocrinologist. So the surgical technique here is going to be the transsphenoidal surgical technique. This is a picture of it. We pass through the nostril to get access to the pituitary gland. So for the surgical procedure, I can't talk about it. We have specialists or even doctors that can talk more about the surgical procedure. So we have to know that the prognosis of the patient depends on the management during the acute phase, because patient at that time can present with severe neurological or ophthalmological impairment, can remarkably improve if is correctly managed at the point time. So the outcome of this with mild sign and symptom can be worse if the diagnosis is delayed. So as conclusion, we can say that pituitary apoplexy is diagnostic and therapeutic challenge, and is a clinical combination of severe headache, vision loss, hypopituitarism, and even with hemorrhage. And in many cases, it is a serious medical emergency that requires multidisciplinary approach, which involve endocrinologists, neuroradiologists, neurosurgeon, and neuro-ophthalmologists. And urgent surgical resection remain the main for acute pituitary apoplexy, especially when we have vision loss of the vision. So thank you.
Well done. Well done, ENDALLE.
Well done, Prof.
Really wonderful, ENDALLE. That was really a good job. Good job.
Thank you, Doctor.
Really well done, ENDALLE. You presented the case and did some good research on the topic. Do you have any questions after reading on pituitary apoplexy? Is there anything that you have questions about?
Yes, I have questions.
Go ahead.
Okay. Okay. At the level of general practitioner, how are we going to manage this patient? Because if maybe the MRI is not available in our area, and you know that if it delays too much, the presentation of the patient can be worse. And how can we do to manage the patient, or it's just symptomatical, like if the blood pressure, the patient is hypotensive, we place fluids. I don't know.
That's a fantastic question. The first response there, I'll start and then we'll give it to, we have a resident here, they can answer. So the first thing, the really important thing first for you, future general practitioners, is to recognize the disease early. You should be able to, when it happens, you should be able to say, I think with the high certainty that this is the disease. That's the first thing. Because if you don't recognize it, you will not be able to manage it. And then the next thing is, you had a slide where the very first thing was ABC. You as a general practitioner can take out the ABCs. Do you know the ABCs?
Yes, doctor.
So go ahead then. What are the ABCs?
Okay, ABCs. A stands for airways. That means you ensure that the nostrils are free, and if there's any foreign body, you remove, and to ensure that the patient breathes normally. B is for breathing, like you check the oxygen saturation to know if the patient needs oxygen or intubate the patient. And C is for circulation, to monitor vital signs if the patient is hypotensive. We put 2 large bore cannula for IV resuscitation.
Exactly. So you've answered the question really, because you need to start by recognizing it, then you ABCs, that means that you will stabilize the patient. Once you've stabilized the patient, you need to transfer the patient. Okay. You stabilize the patient. As a general practitioner, you stabilize the patient and then you send them to a specialized center.
Okay.
Dr. Natalie will give more information there.
Thank you, Dr. Sidney. I'll not come back to what Dr. Sidney said. It is really vital for you to know at least the carnival towards the diagnosis, which we did well. Now, secondly, it is sad, but it is one of the neurological emergencies in tumors that we have. That's why it is being taken like a particular entity usually of pituitary adenoma. People divide it like another clinical presentation because it's the clinical presentation is different from an adenoma which is not clinically or symptomatic. So I would advise any general practitioner, a general physician, to refer the patient to an adequate center. Why? Because the prognosis is not good. We have a functional prognosis with the risk of a patient losing its visual functions, which is really important. And like you said, usually when we have, it can compress other cranial nerves, which passes through that part, and the consequences are still on the visual. However, don't also forget that, remember, on your patient, there was, you cannot transfer a patient who is hemodynamically unstable. So what you do for a start is that you try to stabilize your patient. You can't even do an MRI on a patient who is not stable. You can do a scan, a CT scan, that's if you are in a center where there's a CT scan. But if you're not in a center where there's a CT scan, stabilize your patient first, because during the transfer, the patient can give up if he's not stable. But at the end, you have to refer the patient to a specialist. It is a neurosurgical emergency. You have to keep that in mind. It is a neurosurgical emergency. It is the only pituitary pathology that you have to go for in hours as soon as possible. Thank you.
Thank you, doctor.
Okay, great. Just a couple of questions, not for ENDALLE only, for anyone here. So is anyone ready to describe or define the cavernous sinus? We during this talk, ENDALLE mentioned the cavernous sinus a couple of times. What is the cavernous sinus? And can you describe its anatomy? Anybody? Anyone? What is the cavernous sinus? Okay, so yeah, go ahead.
Yeah, I'm a second year medical student, so we're still getting started with neuroanatomy, but from the knowledge I have of the cavernous sinus, it's like a vein that drains. It's a vein that
already for a second year student, that's a lot.
The blood from the brain.
For a second year student, you already have all the points, so don't worry more than that. The fact that you know it's a venous structure is a lot. So all points, that is a lot. Yes, so you're right about that. You're right that it's a venous structure. So that already is good. Anyone else wants to add something about it? What else do you know about the cavernous sinus? And that it seems like you want to speak. It looks looking great, or is it just the background noise? I don't want to force you if you don't have.
I can help.
Yeah, go ahead.
Okay, the cavernous sinus is found at the middle cranial fossa. So it is laterally to the pituitary gland, and as boundaries anteriorly we have the superior orbital fissure, Posteriorly, we have the petrous part of the temporal bone. Medially, we have the body of the sphenoid bone. Laterally, we have the meningeal layer of the dura mater. That is the diaphragm cell, and the roof, the floor, and the base. We still have the dura mater that overline the sphenoid bone. So, as structures that we have the adjacent nerve, we have the internal carotid artery, we have the oculomotor nerve, we have the ophthalmic branch of the trigeminal nerve. Yes, and we have also the trochlear nerve.
That's good. So I think now you're citing the structures that pass through the cavernous sinus, right?
Yes.
Okay.
Good.
This yeah. Very good. Very good. Very good. So as you can see, poster. So this is this image on the right. That's what you see. The blue part, all that blue blood in all that blue blood is to signify venous blood, and it is inside the cavernous sinus. And the yellow oval thing in the middle is what we call the pituitary gland. Okay.
Yeah.
And then the red things that are round and in the middle on both sides, those are the carotid arteries, what we call the internal carotid artery. And so ENDALLE was given the names of all those yellowish structures inside.
Okay. Okay.
So it helps to know this because whenever there is something happening in this zone, especially around the pituitary, it is possible that that process can cause a dysfunction of one of the yellow or red structures. And so that's how you have a better idea of where a disease can be in the brain.
Oh, okay, that makes sense. Yeah, thank you.
Do you have a question?
Oh, myself?
Yeah, do you have a question?
Although I've just got a question on the definition of pituitary apoplexy. Yeah, because on the it was according to, I don't know if you maybe just go back on the slide. It was talking about impaired blood supply. Yeah, it was talking about impaired blood supply. Yeah, that was the other, because the other one is bleeding into the pituitary gland or impaired blood supply to the pituitary gland. So now I was thinking, what can you also think how would you differentiate it from Sheehan's syndrome?
Very good question. Yeah. That is a fantastic question. That is a really, really good question, and a good question for even a test. So when you talk about, first of all, second year, knowing Sheehan syndrome and pituitary apoplexy, that is gangster, okay? That's next level gangster. So that is good. A lot of people second year didn't know this. So when we talk about Sheehan syndrome, one of the important things, like ENDALLE said, is that Sheehan happens as a consequence of something we call postpartum hemorrhage. So postpartum, that is after, partum, that is delivery. So after a woman delivered, she bled, so hemorrhage. And so when she bleeds, one of the places that suffers is the pituitary stalk. The pituitary stalk is the part of the pituitary that is really tiny and then has it hanging. So that part can, that part there can lack blood. And then so it's, because it lacks blood, if you remember your pathophysiology and anatomy, anatomophysiology lectures, anatomopathology lectures, they told you about ischemia and hemorrhage, right? So if you're talking about Sheehan, it's lack of blood in a person that delivered and then lost too much blood. Okay, so the person was losing too much blood, so there was no blood up there, and she was pregnant. Sheehan. If you're thinking about pituitary apoplexy, this person often lacks blood because there's a local hemorrhage. So they have a rupture blood pools into that pituitary, and then that blood that pulls into the pituitary, so you have the hemorrhage, is equally compressing surrounding structures.
Okay.
So those are the tiny differences. The fact that you just know it in second year is too much, first of all. So anything that we're adding now is just a bonus. Okay, so great question. Dr. Natalie, do you want to add to that?
Thank you very much, Dr. Eric.
I just want to add that it's just a difference between ischemic. Just imagine, it's just like ischemic stroke and hemorrhagic stroke. So if you have the difference between both, you can easily understand what is Sheehan and what is Sheehan and what is apoplexy. But I'm really impressed by the level, Dr. Eric, of all these guys. Like, I'm really impressed. That's really wonderful.
Yeah. So does anyone else have a question? Bejo, do you have a question? If you're around, maybe not. Okay. No worries.
Not really. No, I have no question. Thank you.
Okay. Yeah, I think for the sessions, it's really important that we, when we get, for example, on neuroradiology, for your level, it's more important that you are able to describe a scan, an MRI, than that you should just be telling us this is the disease. Describe it. Start there. Be used to describing, to saying that this is what I see. And then you can say, I suspect this. Don't try to rush too fast. Try to get those skills down, bogged down. The others will come in time. You're already ahead of time anyway. You're doing things that most people do when they get into residency. So get those things down first. Anyway, fantastic presentation. Thank you, Dr. Natalie, and those that attended, and have a great weekend.
Same to you.
Thank you.
Thank you.